Welcome to the Principles of Performance podcast, where we discuss how to optimize your health, fitness, and performance. Drawing on decades of experience of working as coaches, consultants, and trainers to top performers, athletes, and teams from professional sports to top universities to the U.S. military, Eric DeGatti and Mike Perry discuss topics and strategies of how to perform at your highest level and be your very best. Join us and our friends and colleagues who are leaders in the fitness and performance industry as we investigate and challenge the most popular training, nutrition, lifestyle, and recovery protocols. Hey everyone, real quick before we get the show started, I want to share with you something that we're really excited about. Mike and I launched Principles of Program Design just about 2 years ago. And since then, we've been working really hard on building more and more content. And we're finally ready to release some of that great new stuff. We're having a updated version of our original online foundations course where we've added 3 new bonus chapters. We've also updated our live course, and we're going to be doing that in April at Skill of Strength in Massachusetts. We also have 3 brand new online courses, including our exercise coach course, where we teach you our belt system of how we progress and regress and coach exercises, as well as group mastery, where Mike shares his systems for how he implements his successful group fitness training programs up at Skill of Strength, as well as something called Primed, where we teach you about programming warm-ups. And then in addition to that, we're also launching a virtual mentorship where we're going to work hands-on with a select handful of coaches and trainers working with you every week on how to develop the best systems and programs to build a successful career. And then in addition to that, we're putting together a free ebook as well as a supporting webinar where we're going to give you our top 10 tips to a successful career in the fitness industry. We're going to share with you our secrets and our systems that we use that have helped us open up our facilities, as well as speak around the world and work with some of the best athletes out there. And so to get more information on all of this, go to principleswebinar.com and you can find out about all the new and exciting stuff. Now, let's get started with the show. And away we go. Here we are with the Principles of Performance podcast. I am your host, Eric DeGatti, along with my friend and co-host, Mike Perry. We are at episode 69, and this is a pretty important one, Mike. We get this topic coming up quite a bit.
I think everybody in the whole entire planet knows about this topic because they've probably experienced it at some point. But before I go ahead and steal your thunder, I'm going to let you introduce our guest for today.
Yeah, he is, as you like to say up in Boston, this guy is wicked smart.
He's a Boston guy, that's why.
Yeah. We got Dr. Kyle Matsel, and he's on the faculty at the University of Evansville out in Indiana, and he's an associate professor of physical therapy where he teaches in the musculoskeletal content areas of the Doctor of Physical Therapy curriculum, and he's also the program director of the PhD program in health professions education. Got his doctorate in physical therapy, University of Evansville. He's got his PhD in rehab sciences from University of Kentucky. His research interests are in identifying musculoskeletal injury risk factors, which we're going to talk a whole bunch about, and implementation of arm care exercise programs for baseball players. So if we have a little time, we might sneak in a little baseball, and I geek out about that. But he's also director of ProRehab and University at Evansville Sports Physical Therapy residency program, and he's a board certified clinical specialist in sports through American Board of Physical Therapy Specialties, and is a certified strength and conditioning specialist. Now, he presents nationally on topics from related to comprehensive systematic movement-based assessment and testing, and is a consultant with a number of collegiate and professional sports teams, and he's a good friend, and we're happy to have him here. Welcome, Dr. Matsel.
Oh, thanks, guys, so much. It's really, truly an honor to be on here and have a little time to discuss some topics that we're all passionate about.
Absolutely. Absolutely. Eric, before we dive in, anything you want to start off with? You want me to get rolling?
Dive in, buddy. Let's go.
All right. So we're going to be talking about low back pain, but let's start by talking about how much of a problem it is. Can you give us some basic stats on how prevalent low back pain is in Western society and the impact it's made both individually and globally?
Yeah. Well, it's very, very prevalent, right? It's everywhere. I teach entry level DPT for physical therapy students, and one of the messages that we always are giving our students that are going into outpatient physical therapy practices is that you are going to encounter low back pain. There is no way around it. You have got patients that are going to be coming in at all spectrums of low back pain: acute, chronic, subacute, radiculopathies, muscular, joint. It really doesn't matter. There's so many different versions of it, and the prevalence is so high. I mean, one statistic that I recently had read that it's really over 50% of all of the caseload that their typical outpatient therapist sees. So 50% of your working day is largely going to be dealing with low back pain if you're a rehabilitation therapist in an outpatient setting. Worldwide, globally, it's an epidemic. You're talking, almost a billion people worldwide. I mean, 700, 800 million people worldwide currently with low back pain. And the thing of it is, it's a large contributor to disability. It's a large contributor to work-related difficulties, but only about half of those folks are actually even seeking care. Half those people are actually even going in to rehabilitation and getting the treatment. So it's a big problem, and there's a lot we could do for it.
So one of the questions that I have for you is, as far as low back goes, is this is what everybody comes in and says. I've got a slip disc, or I've got a bulge disc, or I have a bad disc, and it seems to me that everybody categorizes low back pain as a disc issue. And do you think that's because of like a lack of the ability to truly diagnose, or is it a very generic term or general term, just like adding an itis or a tendinosis on the end of something? I mean, why do you feel like so many people are blaming it on discs?
Well, it's something culturally I think we kind of bring up. We like to blame pathoanatomical lesions whenever we can, right? It's just simple. It's the traditional medical model, right? It's no one's fault. It's just literally just how it was introduced traditionally. You come up through medical school, you come up through physical therapy school, you got to blame something, right? And I can take a radiograph, I can take an MRI image, I can see, look, there's a little abnormality, there's a little lesion, there's a little disc problem. That must be the root of all evil. That must be the thing that's causing all your pain. And as we've learned over the years, it's very rarely is that really the case. It's so many of these discs and degenerative changes. There's just natural consequence of aging to some degree. I mean, so a lot of them are completely asymptomatic and are causing zero problems. We actually are causing more problems sometimes identifying them on the scans and then, put them on a pedestal, because then it freaks the patient out largely. And then they're like, oh my gosh, I have a disc. Oh my gosh, I have degeneration. And that actually does more mentally to cause, pain and disability for the patient than it does even physically. So it's a big issue for sure.
Yeah, well, we could talk about the labeling of that, and we're going to definitely circle back about the significance of imaging and so forth in a little bit. And sometimes I think it's just because it's the only thing people know in their back. It's like with shoulders, when how many people come, hey, I got a rotor cuff issue, because the only thing they know is their rotator cuff, and they don't even name that right. So, but I digress. I want to kind of go early in on this and pull the pin and roll the grenade under the door, Dr. Matsel. And let's talk about injury prevention, which is something that will set off a fury if you put that out on social media. And there's a lot of debate about it, right? Is there anything that we can do to prevent or at least mitigate the risk of low back injuries?
Yeah, great question. And that's really the $1 million question. I mean, we're, as a society, moving a lot more towards being proactive, trying to recognize risk factors, try to recognize what we can do to, mitigate, manage, keep these episodes of low back pain down, because economically it's a great burden, right? I mean, so we're really, insurance companies are finally getting on board with, we mean we need to be doing some things and some testing and some screening to be able to reduce these from ever even turning into a large economic burden. But with that to say, I mean, the problem with back pain is it's so multifactorial, right? It's not as simple a lot of times as just blaming a particular muscle or a particular joint or one particular movement. Like most things, it's very much multifactorial. Sure, core stability. Sure, mobility problems at the hip and pelvis. Sure, mobility problems at the T-spine. And you can even go all the way down the chain to the ankle. I know that regional interdependence is a real thing. We all like to look at movement and try to integrate that into our function. So certainly all of these impairment measures, to in one degree or another, have been shown to be independent risk factors of back pain. But let's not fool ourselves. It's not that simple, right? Because lifestyle plays a big role. If you're only sleeping a couple hours a night, if you're not well hydrated, if you're not eating a good diet, then those things are going to cause your back to be in a bad place as well. The back is just a frequent area of the body that manifests symptoms, for sure.
Now, what are some things, whether on the professional side, whether I'm a rehab specialist and clinician, or even on the fitness side, what are some, or even down to the layperson who's actually experiencing this, what are some of the things we can do in terms of early detection? And the reason why I asked this question is because I actually had a post about this a couple of weeks ago, and I used a pop culture reference that really dates me. All right, now let's see if you remember this, Matsel. Do you remember the Woody Woodpecker cartoon?
Oh yeah, of course.
Okay, so one of my favorite episodes is if Woody would have went straight to the police, none of this would have ever happened. And so I use that reference with my clients all the time, because I said, look, you needed to come in 6 months ago, and this would have been a whole lot easier, right? So guy I saw this morning, he was dealing with back pain, but he kind of ignored it and did the Advil and ice kind of deal to get him through, until eventually got so far along he sought out help. And now our job's a whole lot harder. So talk about what we can do in terms of early detection and how important that is, so they don't get to you in a clinic where it's so far gone that there's not a whole lot you can do.
Yeah, no, that's great. Absolutely. Woody Woodpecker just became popular for my 3-year-old here recently. He's just discovered Woody Woodpecker and is watching some shows and stuff.
Spectacular. Good parenting on your behalf, Matsel.
Exactly. I always think about a story that Gray Cook actually told me a long time ago. He said in one of his early jobs, he was working in a hospital, and he walked into a room, and the patient was there with low back pain, and they reeked of cigarette smoke, was sitting there drinking a Mountain Dew, and was probably 50 pounds overweight, and was like, yeah, help me, my back hurts. And it's like, well, of course your back hurts. I mean, I don't have to do even a musculoskeletal exam on you at this point to tell you that that there's probably going to be some stress on your back. And so I think the first thing is we really need to create some awareness and to the general population about, it's not just all about core stability. Like I've had patients even today that they come in with their low back, and they're looking for the core stability exercise or the right stretch to improve their low back pain. And the problem with it is a lot of the core stability that they're doing that's, on the market or on the internet is actually maybe even feeding into their problem. And the stretching that they're doing, they don't need, because they're already hypermobile, right? So it's a lot of times, they're not in the right place, but they're trying to manage their symptoms through Google or through the internet or through curbside PT that a buddy gave them, and that just doesn't work, right? They need to get in and get looked at, and they need to do it sooner rather than later, kind of like you're alluding to. The thing that I think the way of the future is, because it tends to be human nature to some degree for people to put their symptoms off, right? I mean, we've been doing that since the beginning of time. It's like you have to literally be on fire and bleeding out of your eyes before you go to a doctor a lot of times. And so it's not surprising that, you have all these millions and millions of people with low back pain, yet there's only half of them are actually even getting in and consulting with a therapist or an athletic trainer or a medical doctor, right? And in that regard, a lot of times the care they're even getting, if they do get there, is so unimpressive that they're like, well, I'm not going back, right? And that's a whole another problem. But I think the way of the future is really trying to create a mechanism for people to kind of self-screen themselves a little bit and start to create that awareness for them and self-check themselves. One of the big things that really helped with blood pressure management and diabetes management several years ago was really the ability for people to go in to a CVS and stick their arm in those automated blood pressure machines. And then eventually that turned into affordable cuffs that people, electronic cuffs that they can take home and they can monitor their own blood pressure. They can go and stick their own finger and get blood glucose readings, and they can kind of track those metrics. So, when they know that they have a problem, they now have a mechanism to see, okay, am I in range? Yes or no. And if I'm out of range, maybe this is a reality check that I need to go in and get more professional, more one-on-one type of care. But I think a lot of people are walking around out there just thinking, oh, it's back pain. Everyone's got back pain and I'm just getting older and, I just got to deal with it. And that's really not the case.
Yeah, I mean, the low back pain is a tough one because I've seen every single thing out there. I mean, so many people have come in and gotten referred to me because I've been able to help people with low back pain. And 9 times out of 10, I'm like, let me guess, you did bird dogs, bridges, and clamshells. And they're like, yeah, and it didn't work. I'm like, of course it didn't work because you did the same thing over and over again, and you never actually graduated onto anything that was going to move the needle. But let me ask you this. For some reason, people think that just doing a bunch of flexibility work is going to solve all of their problems. I've had so many people say, well, you just need to do more yoga. And if you do yoga, your back will get better. Or if you do hot yoga, it'll even get even better because it's hot, right? And same thing with Pilates and this and that. Why do you think everybody is so hell-bent on stretching their back pain away?
Yeah, it feels good, right? Stretching feels good. People can feel it. It doesn't really take a lot of effort. They can just feel it and stretch it. And, again, culturally, they've just been kind of put in their mind that, oh, well, I must just, if I stretch, I'll just feel better. And they probably do a lot of times. Like you stretch yourself and, for at least the next 5 or 10 minutes, you probably do feel a little bit better until you actually stand up and start walking around again. Right. But I think that, we just, in our mind, we just have that sense that, oh, this is just what I need. Now, the problem that's leading to the catastrophe that we're seeing with back pain and disability shooting through the roof is that nowadays what you actually have is you have people that tend to be a little bit more hypermobile, right? Now, maybe 10, 15 years ago, there was a lot of really tight, young athletes, tight, college athletes, professional athletes, and stretching came in, flexibility work, mobility work, the importance of that. All these risk factors tend to be mobility related a lot of times. So people became aware that, oh, I need to stretch, I need to do mobility work, I need to foam roll, I need to do these things. Great. So people started doing that like crazy. And now what we've actually got is really strong, really powerful, hypermobile folks, right? So then they actually have all this strength and all this high threshold, kind of strategy going on with no inner core stability, very poor coordination and motor control throughout the body, movements kind of not so good, but they can fake it till they make it because they've got pretty good mobility. Right. And then they're good. We tend to do things that we like to do. Right. And then people I like to stretch. I'm pretty loose. I'm pretty mobile. I have a problem. I'm going to do the thing I like to do. And that's stretch. So they just stretch more and they make something that's relatively unstable, even more unstable, if that kind of makes some sense. So you're just kind of stretching, a temporary neurophysiological relief of tone. And then it comes right back. And the overarching long-term consequence of that is you're just continuing to add fuel to that fire.
There's a couple points that I want to take and run with this topic, Kyle. One is some of that is what I call the ask your doctor syndrome, like drug companies say, like ask your doctor. Like we could all pick up our phones right now and the three of us could not have to scroll long before we find somebody that says, hey, can you give me some stretches for my back? Right. And how many clinicians, PTs, strength coaches and trainers are just sending back pictures of stretches, right? Because it's an easy fix because they're asking for it. Here's your stretch. When the first question I ask is say, well, why do you think stretching is what you even need? How do you even know that that's the problem? Now, that's part of the issue. Part of the issue also is because I think, like you said, so much of our interventions are so mobility biased that a lot of the motor control people, and to Mike's point, where they've gone to PT, they've gone to this one and they failed, that get to me almost always are big motor control issues because we don't have really good diagnostics for that. So let's talk a little bit about how we detect someone who may be on that hypermobile scale, and B, detect where they may be falling short on the other side from a motor control standpoint.
Yep. Yeah, no, you're right on the money there. I mean, I do this activity with my students every year to bring awareness to this because, yeah, just to put this in perspective, I'm teaching in a doctor of physical therapy program with, these students are, I don't know, 22, 23 years old sometimes, embarking on a doctorate, crazy smart, crazy motivated, good students, exercise science background, athletic training background, all of them, right? And in the very first year of their fall semester, I teach a therapeutic exercise class, and they all kind of roll their eyes. Oh, therapeutic exercise. I just majored in exercise science. I know all that stuff, right? And the very first thing that I do is I bring up everyone in the room that can't touch their toes, right? And I just say, all right, everyone stand up, see if you can touch your toes. People that can't touch your toes, come up here. And I go through and I kind of do a little quick check to see, is it truly people that you can't touch your toes because you're tight and have a mobility problem? Or is it truly that you can't touch your toes because it's that motor control, coordination, strength thing that you're talking about? So I differentiate that very quickly. I usually have about a 50-50 split. And I set all the people that are tight down, and I leave the people up that have the motor control. And all I do is I let them breathe. I go through diaphragmatic breathing throughout neurodevelopmental postures, supine, prone, quadruped, kneeling. Just sit there and just breathe. It takes about 5 or 10 minutes. I'm sitting there talking, coaching it. They're all breathing up here in their upper chest, no diaphragm, all high threshold, right? And I get them breathing through their diaphragm, calm all that down. 5-10 minutes later, they stand up. Every single one of them touch their toes. I've been doing this for 8 years, same activity for 8 years, and it always works every time. And it's the great way to show these exercise scientists, athletic trainers that are getting ready to embark in a doctoral program that it's not as simple as just kind of making an assumption about someone's mobility, stability, and throwing a bunch of exercises at them and hoping it's going to work. You've got to do a little bit on the back end here to see if what you're going to do is actually going to be beneficial. So all that to say, I just think that it's so important for us to have a little bit of a system in place and be a little bit better than just shopping the next 3 good exercises out. I used the word curbside PT earlier. I mean, you imagine I've got students, I've got friends, family members, we all have had these folks that call you up and say, hey, Eric, my knee's hurting. Can you give me a couple exercises for that? And I'll tell you, I'm probably 0 for 1,942 on making people better with curbside PT. Like anytime a family member or a student or anyone comes up to me and says, my shoulder hurts, my back hurts, my knee hurts, whatever, give me 3 exercises. And if I were to oblige them and say, okay, do these 3 things, try that out, guarantee you they're not going to be any better, right? Because I don't know, right? It's got to be more specific than that. You've got to get in there and evaluate it. So systems in place to do that.
All right. So 2 follow-ups on that. So talking about evaluate it, talk about a little bit about something like the Beighton scale and kind of how relative and accurate that is for someone either on the fitness and training side or the rehab side in terms of gauging someone's just general tendencies towards hypermobility.
Yeah, Beighton criteria has been around a long time, so it's super simple. I've really started to just kind of include that as part of my standard evaluation just for everyone. Because again, the people that you think are hypermobile are not always the case. And the people that you think there's no way this person's hypermobile, you'd be surprised. And it takes literally no time. It's check hyperextension at the elbows, check hyperextension at the knees, palm the floor on a toe touch. Can you get your thumb down to your wrist? Can you dorsiflex your finger past 90? It's scored out of 9 points. Usually in that 4 to 5 range out of 9 is where you start getting concerned about, this hypermobility. And there's been some good studies that have gone out and looked at the Beighton criteria and have showed, it's got some validity to it. And actually people that are, have some hypermobility measured by the Beighton criteria are actually a little bit of increased risk for injury. So I think being aware of that is really important. Now, you may not always be able to modify it. Sometimes there are people that are born, we used to call it double jointed, right? And it's not double jointed. It's just that you're just a little bit loose. You move a little bit more excessively. But those people, maybe that's their anatomy. Maybe that's how they're born. It may not ever go away, but you need to manage those folks a little bit differently, right? And that's why it's important that you know about it, because if you're coming in with low back pain and you're hypermobile, the last thing I'm going to do is stretch you, right? Even if I find a couple mobility problems. And I'm going to say that again, because I think that's really important, because I think that a lot of my students, this is where students are very black and white, right? And as professionals, this is why we're professionals, because we can think outside the box a little bit. Someone comes in with mobility, they've got one mobility problem and 20 motor control problems, and they're hypermobile. That one mobility problem very well might be the one thing holding them all together. Right? It's kind of like the parking brake I've heard Gray use, or it's just a protective mechanism that's trying to keep them stable. And then a lot of times an ambitious therapist might come around and say, oh, I'm going to drop some needles in that, or I'm going to manipulate that, or whatever. It makes them a lot worse, right? Actually can do some harm. And again, I've been on the end of that. I've had plenty of folks that have come in that, you try to do something quick and, try to make an impact quick, and it's too much for them to handle. That mobility problem was there protecting. So you get a lot more effectiveness. You get further with those people by actually getting more motor control, get the tone down, get the tension down. And a lot of times those little mobility problems, they bleed away. They're gone, right? They weren't even really a factor. They're just more of a side effect. So the only way that you can find that, though, is if you do a really good evaluation. So you've got to come in, and I know you guys both, like when you're working with your athletes, when you're working with your clients, I mean, doing some checks and rechecks, doing some biomarker checks. How you breathing today? How's your grip strength today? How's your biting criteria? Do some quick, movement patterns, see if there's any pain. How'd you sleep last night? I think these check-ins are really, really important before we just start going and treating everything. And I think that's, kind of circling this all back around, is back pain management is so poor, because again, you get back pain, you go to therapy, you get the same standard set of exercises, it doesn't work, you get discouraged, you go get a doctor, they do MRIs, they do injections, they do more MRIs, and they say finally have some surgery, and maybe you're better, maybe not. A lot of times you're not better. There was a study that I read that came out 2 years ago that actually said that a third of people that have had a spinal fusion, that went in and got because they're having a lot of pain, they went and got a lumbar spinal fusion, continue to use the high dose narcotic type pain medicine. So, I mean, a year after surgery. So these are folks that have pain in their low back. They, assuming exhausted all their other resources, go and get spinal fusion surgery, and then they come out of it, and a third of them are still taking the high level pain medicine. So again, we're mismanaging these folks. I just believe that.
All right, so I'm going to throw a little something at you. So when you're looking at the Beighton scale, right? We've got a 9-point scale. Have you found it sort of working with all these individuals that you work with, that certain assessments from the Beighton scale carry more weight than others? So for example, if we look at an athlete, right, and they've got 2 elbows, they've got 2 knees, and they can palm the floor, but the pinky and the thumb are considered normal, are you going to approach that in a different way based off of how they're accruing their score? Or are you going to still say, look, there are some trends that say this individual may have some hypermobility, some laxity, and we need to pay attention to that?
Yeah, that's a really good question. We actually looked at that for a long time internally. We collected tons of Beighton criteria data, and other stuff too, grip strength, movement patterns, you name it. And we were looking for exactly that. Like, is there one particular point of the Beighton that is more weighted more than the others, right? And that's fundamentally what you're asking. And we assumed, our assumption was it was going to be the toe touch. It was going to be that if you can palm the floor, on the toe touch, then that was probably going to be a better representation of the whole type of thing. And it's not as simple as just one factor. So it was toe touch did tell us a lot about it, but it really was toe touch coupled with some hypermobile joints at the elbow. The fingers and the hands, it didn't matter as much, at least in this data set that we had. But if you had someone who can palm the floor and they had hypermobility at like their elbows or their knees, that tended to tell us quite a bit.
So for people at home who aren't familiar with the Beighton scale, we're going to put a link in the show notes. I actually wrote an article on this specifically, and I describe what the Beighton testing is and how that kind of affects and impacts some decision making. But speaking of impacting decision making, we talked earlier about diagnosis and pathologies, and then the significance of MRIs and X-rays. Now, in the research I've shown where there's a high percentage of times where that doesn't actually change the course of treatment at all. As well as even in conversations with clients, getting them to understand that. So as an example, I had a guy in who was a Division I football player who was dealing with some back pain, who came into me and says, well, and he starts explaining his pathologies of his disc and so forth. I said, how do you know you didn't have that from a tackle your senior year in high school, right? And you're 36 now. How do we know that that's the driving, not the driver here, that wasn't there for 10 years? How do we start to distinguish how much prevalence and weight we actually put into what you see on your MRI?
Yeah, it's great because, again, traditional medical model, traditional physicians, they love to get their imaging, right? And, it's just kind of standard practice. You go in, hey, something hurts. Okay, great. Here's your round of x-rays, just like clockwork, here's your medicine for that. Come back 2 weeks later. Oh, you're still hurting. Okay, let's try PT for 6 weeks. Okay, that didn't help. All right, now here's your MRI. Oh, that didn't. Now we see some stuff on the MRI. So now we're off to the injection to try that route. And again, you can just see how this snowballs, and it gets, kind of out of the way, gets carried away pretty quickly. Imaging just doesn't really tell us the whole story. I think that, when you have someone that has trauma, you have signs and symptoms that match the MRI. So like if I've got someone that has drop foot and, they can't walk, because their foot's slapping the ground and they got numbness and tingling and weakness given out. And that's a relatively new phenomenon that occurred right after they bent down to pick up their kids off the floor and they have some hot disc type symptoms. Okay, I could get on board with maybe that disc is symptomatic for sure, and that probably needs imaging sooner rather than later for sure. A young athlete, I've got, tons of younger athletes that are, middle school, high school age with really bad extension-based back pain. They play extension-based sports where they're constantly, getting beat up. They're a football quarterback, they're a baseball pitcher, they're a lineman, a gymnast, whatever. And so then they constantly are getting hurt more and more in that extension lesion. I want that x-ray a little bit sooner for those folks, right? I need to make sure there's not a fracture, not a spondy. So those type of things matter. Younger folks are more apt to get the imaging early and listen to what the imaging says, right? Because if the imaging in a 16-year-old says they got a bulging disc, that actually has more weight to me that maybe that disc is actually contributing to their problems. That's less than ideal. Now, you take that to a 45-year-old, I would say if I were to look at an MRI of a 45-year-old, I'm absolutely going to see a bulging disc. I would be surprised if I didn't see a bulging disc on there, right? And if you have no symptoms clinically that match that bulging disc, I would say that that's probably an artifact of aging. So, and so we get all in a tizzy sometimes about, oh, you bought a bulging disc. Let me start the bulging disc protocol. Let me pull out my 3 exercises that I have in my file cabinet that treat bulging discs. And the disc isn't even contributing to the problem, right? And I think that's where we lose our objectivity a little bit. And so that's where the diagnosis actually hurts us.
Hey, everybody, a quick break in the action here. Hope you're enjoying the show and we appreciate you listening. We're working hard to bring you the highest quality content and best guests every single week. So if you could do us a big favor and go and like and subscribe to the show on whatever platform you get your podcasts on, it would be greatly appreciated. Be sure to listen at the end of the show also to find out where you can find out more information about our courses, as well as a special discount code for all our listeners. Thanks again, and let's get back to the show. So I want to go a couple more points on that. So one is the problem is that it's not always as simple as the dogmatic way of thinking is, well, if I have a disc issue, I'm going to avoid flexion and I'm going to do a bunch of extension-based activities. If I have anything spondylolisthesis, stenosis, something more facet-driven in my spine, I'm going to avoid extension and do more flexion-biased things. But it doesn't always work that way, does it? Right? Sometimes it's a complete opposite.
Absolutely. That's why you got to do the assessment. You got to do the test. I mean, I've had people before, and I wrote a book chapter on this years ago. A group that was putting together a book on clinical reasoning, and they said, "Hey, you got any cool case studies?" And I was like, "I don't, but I can do one if you guys want." And so next week, grabbed a patient that had low back pain, radiculopathy, that thought for sure the world was going to do some extension exercises and just clear up his radiculopathy like that. And it actually was flexion that helped him, like we did flexion. I was doing extension, he kept shooting down his leg. And I was like, oh, this doesn't make any sense. Of course you have a bulging disc. You have to have. He was young too. I think he was like in his, late 20s. And, so definitely wasn't thinking stenosis, wasn't thinking anything like that. But, we did flexion. And all of a sudden the symptoms just centralized. He felt better, and really, honestly, just like a handful of visits, and he was doing great. Starting with some flexion, peppering in some good regional independence and some movement too, but getting him centralized first with the flexion was key. If I would have banged out extension on him for 6 weeks, of course he would have been frustrated and annoyed and more painful, and probably would have fired me long before that. And then he's off to surgery. Right. So it's just, we've got to be objective, and we got to trust sometimes the evaluation process and what we're seeing and what the patient's telling us, as opposed to, putting all of our eggs in the imaging bucket. Right.
So
now, go ahead, Mike.
I was just going to say, one of the things that Eric and I talk about is in one of our courses is just asking the right questions and the importance of communication. And one of the things that I always add in with my low back clients is, when your back hurts, like, what position feels good? And sometimes it's flexion, sometimes it's extension. To me, that's part of the assessment, because they know what will make their symptoms worse and what will also potentially make them symptoms a little bit better. So, sometimes just asking, does it feel better to do this? Prone press up, extension bias, or flexion? And a lot of the times that'll tell me a lot about where I need to bias all of their drills, how we have to put their pelvis, and how we want to set up everything once we get that basic information. So, everyone's always so concerned about what's the best exercise, but quite often you just have to ask some key questions. You'll get a ton of information that is, a lot of the times, even more important, just the basic assessment where you watch someone move.
Well, what's the old statistic that we still teach our entry-level students is, if you just sit back and listen to the patient, they'll tell you exactly what you need to do. And that's true a lot of times. They'll tell you exactly what hurts and what helps and what they've tried that doesn't work. And, they'll give you tons of information. And it was like with not to dog medical doctors, but this study wasn't very fond of them. It said that the medical doctor on average interrupts the patient's subjective histories 6 seconds into it. So it's like, all right, tell me why you're here. Well, thanks for seeing me today, doc. I've got some low back pain. It started. Okay, let me stop you there. What kind of back pain? I mean, they interrupt the patient and they get them off the course of their story so frequently, it's hard for them to get a clear picture, right? And I think something that rehabilitation professionals, fitness folks do a good job of is listening to the patient. At least that's been my experience. Now treating it and objectively getting down the right path, I think we can still be better there. But at least I think we're also, as a profession, we listen and we care a lot about our patients, for sure.
Now, what makes the picture even fuzzier is the timeline that you alluded to earlier. And there's two ends of this. One is if I have those symptoms and then I go, okay, so I go maybe because I don't know any better, I go to my general practitioner, who's going to then refer me to a specialist, who's then going to send me out for imaging, who then I finally come back and get the images read. And by the time I finally get into your hands, weeks have passed, if not more. Right. And so had you gotten me just day one, if I could have just walked in, and this is one of the benefits of direct access, but had I just gone in day one to you, that it probably would have been cleared up, kind of like our story earlier, cleared up a lot easier, but it's so far gone now that it's a significantly worse problem. So that's on one end of the spectrum. And then there's also the research that showed, like, if you were to just do nothing, it's going to go away too sometimes. Right.
Well,
and that really confounds it a little bit more.
Well, it does. I mean, there was a systematic review that came out a long time ago. It's probably 20 years old now, but it was a very high level systematic review that basically said that you have back pain and you do nothing for 4 weeks, that you're going to be, 60 to 85% better. And that's just laying on your couch doing nothing. Right. So a lot of people bet on nothing. Right. It's okay. Well, go to PT, go do exercise, take pain medicine, whatever, or go do PT. They say, oh, well, maybe if I just, ride it out, it'll get better. So I think it is confusing, but I think that those times are going away. I will say we have evolved quite a bit away from that. And I had an old roommate of mine that we went to undergrad together. He was a biology major. I was an exercise science major. I was going on to PT. He wanted to go on to medical school, is what he really wanted to do at the time. And he didn't end up going to medical school, but he did end up going to physician assistant school. And he was down in Kentucky doing his physician assistant training. And I had just graduated from PT school, and I was down in Kentucky working too, outpatient clinic. He called me up one day. He goes, "Hey, you mind if I just come and hang out with you for the day and shadow you? And I just want to see what PTs do and what they're all about." And I said, "Yeah, sure." And of course, the first patient I had was someone with acute back pain that just, they just really flared up, just really painful. And for this particular person, they fit a mobility kind of category where they did indeed need some stretching and some joint mobilization work. And they, I did my exam and found that. And so I manipulated the spine and worked on soft tissue of the spine and really did a lot of exercise. And my friend, that was in PA school, his jaw was on the ground this whole time. And the patient left and he goes, "What in the world are you doing?" And I'm like, "What are you talking about?" He goes, you got that patient doing exercises and doing things like already, like they told you they just had back pain like a couple days ago, and that's you're already doing that stuff. I go, "Well, yeah, we want to get them up and moving and move as quickly as possible." And he goes, "Oh my gosh, and in my training at PA school, they just teach us for acute back pain to put them on bed rest for 2 weeks and give them pain medicine." And I'm like, wow. Wow. So it's out there, but I will say, I think that is a dying trend. I think we are better about trying to encourage people to get to therapy, get to medical management sooner. Now, whether they always abide by that or whether they get good quality therapy, that's maybe a different story. But
well, let's talk about that story, because the common story that you hear, especially people who've had chronic low back issues, is they come to Mike or myself because they've given up. Because look, I've tried acupuncture, I've tried chiropractic, I've tried this, and I get temporary relief. I feel a little better, but if I'm not going there 3 times a week, I only feel good when I immediately get off the table and walk away. And so, I just had this question the other day from a kid who's getting recruited for Division I soccer. And he said, "Would I get any benefit from physical therapy?" And I said, "Well, you have to that depends, right? It depends." I said, if you go in and they give you the same stuff for your knee that the old lady across the room is getting, then you're probably not getting anything out of this. I said, if they actually do some sort of evaluation and they give you something specific to you and that's tailored and that's progressive, then yes, absolutely you can. But if you're doing the same 3 exercises that, if you look around, they're all doing the same 3 exercises, then you're probably wasting your time. And so talk a little bit about how we don't have a common language and operating system for care across, not just through rehab, but across all our disciplines, even for you and I to communicate.
Yeah. No, you're exactly right. It's a shame. And, if you go into a medical doctor's office, and it really doesn't matter what part of the country, it doesn't matter, really what where the doctor's training was, you're going to get somewhat of a standard medical evaluation, right? You're going to go in, they're going to get your height, weight. They're going to, maybe have you pee in a cup. They're going to, ask you about allergies and medication changes. They're going to take your heart rate, your blood pressure, they're going to take your temperature. And again, you may be there just because you have a sprained ankle. You may be there because you have a sore throat. You may be there because you're just getting a checkup. They still do all those things, right? Regardless. Now, what we do in physical therapy or even in fitness, it's okay, why are you here? Well, I had low back pain and my physician said I should come in and get some exercises. Okay, great. Here are the exercises that I like to do for low back pain. Let me try those first. Oh, those don't help. Okay, well, let me try now these exercises and see if those help. Oh, those help maybe a little bit, but not a whole lot. Okay, well, let me now progress those exercises a little bit. And again, it's just more of a lot of guesswork, right? And it seems like you're throwing darts, hoping that one of them is going to stick, is what that feels like. And again, I've seen personal trainers and strength coaches do the same thing, where clients goal, I want to get in, I want to lose weight, I want to run faster, jump higher. Okay, great. Here's what I like to do. Here's the program that I do that makes that happen. but it's not individualized. It's not tailored for the individual. So I think that we can be better at that. So with that said, we need a systematic approach. We need something that we can all talk about. And that is the one thing that, like, like functional movement systems does a really great job of. I mean, they're really the leading innovator with systematic movement evaluation and testing, right? I mean, I just don't know another system robust enough with the stack of literature to the ceiling that has really shown to be a classification model to get people where they need to be and managed correctly, right? It also creates great communication within the clinic. Like, I've worked with several physical therapist assistants over the years that, again, we can be on the same page, even if we're not even direct communication or direct line of sight. They can read what I've written in my diagnostic algorithms and follow that through the SFMA system. And then I've worked and consulted with a lot of fitness professionals too, that they're also getting, performance training, while I'm seeing them in the clinic. And guess what? We can communicate too, because I've got FMS scores, functional movement screen wide balance scores. Like, hey, here's the painful pattern that we want to avoid for now, but oh my gosh, all these other patterns are, go for it, train the heck out of those. And I'm working on this pattern from a corrective exercise perspective, but if you've got other exercises that you want to throw at that to make that better, go ahead. But again, we can create a network and a dialogue to work together, because I think naturally, and this is what most new personal trainers have said to me, when I'm the new kid in town, I come in and say, let's create a relationship. The first thing they say is, if I refer all my athletes that are having pain to you, I'm going to be out of business, because there's no one. I'm going to give them all to you and they're never going to come back. And that, again, that's not what I want to have happen. I don't want to, poach patients. I want to get a patient, identify what's creating stress and pain, and you keep training them, keep working with them. But let's not do things that are causing that are expediting their pain. Right. And same thing is, we need, from the fitness and strength and conditioning perspective, at some point, this athlete's going to have to lift heavy things, right? I think another pet peeve I have in therapy is we don't take a very good strength and conditioning approach. We are doing, 3 sets of 30 with little 1 pound weights. We're saying, oh, it hurts to run. Let's just not do that anymore, or run less, or just cross train. Again, maybe there's a time and a place for that, but largely the person wants to get back to doing those activities. And I think we have a big underdosing problem in physical therapy, where we just aren't preparing folks. I don't know if you guys see that in your practice or not, with people coming bouncing in and out of rehab, but I just feel like, physical therapists generally don't understand strength and conditioning principles, nor do they load the patient appropriately enough with appropriate amount of weight to even prepare them for the loads of everyday life.
Well, yeah, on our side, we don't understand what you do enough either. And nothing, to your statement earlier, if you are a fitness professional, strength coach, and you make that statement that you said earlier, that, oh, I'm scared that if I refer somebody to Kyle, that I'm going to lose a client. Nothing, that's a red light screaming that I am a shitty fitness professional if I'm scared of that, right? If I'm intimidated by that. But go ahead, Mike. I know you have your next question you want to roll on to.
Yeah. So what other lifestyle factors do you think contribute to low back issues? And also, let's talk about a differential diagnosis, because there could be some medical issues, right? And how important is it for people to get a second opinion in a differential diagnosis?
It's great. It's crazy important. I mean, now here's the good thing. I'll start with the good thing. The good thing is, these severe sinister conditions that exist, you think about cancers and bone cancers and fractures and breaks and all the scary stuff, that you don't want to run into. They're very uncommon. A lot of times they've been screened out well before they get to the therapist or to the strength coach. A lot of times, these are identified, and very rarely, I say less than 1% of the time, there's some data on that, I'm not just guessing, less than 1% of the time that their back pain is actually cancer or whatever. Now, not to say that you shouldn't check it and screen for that. And the best way to do that from a differential standpoint is to make sure you cover all your bases, just like in a systematic approach that your medical doctor takes: height, weight, blood pressure. They always do it no matter what. we should get in the habit of always doing neuro screening, reflexes, myotomes, dermatome checks, always asking about, where the pain is, does it move, does it travel, always asking about lifestyle and any changes with like bowel and bladder function or recent infections and fevers, those type of things, because those sinister conditions or constitutional symptoms, if we're getting multiple checks in that category, then we're gonna want to refer them. We're gonna want to get imaging, and it does happen. There are people out there that truly need surgery, that truly have conditions that mask themselves as musculoskeletal pain, and so we don't want to miss that. I mean, I had a patient several years ago that was 75. He had low back pain. I couldn't find the pain. Like, I was literally poking, all prodding, stretching, moving, couldn't reproduce it. Treated him one session. He said, it's the same. I said, this doesn't smell right. Send him back to the doc. They did some blood work, and he ended up having diverticulitis. They put him on some medicine, and guess what? He called me a week later and said, great, I feel great. I'm so glad you sent me back. I'm like, okay, great, but I mean, I'll take half the credit for it. But I mean, it's really making sure that we are addressing what we need to address, and then referring out when we need to refer out. Yes.
Mike, a guy with a story like that, right?
Yeah, unfortunately. Yeah. For those of you that don't know, I've had chronic back pain on and off actually throughout my life. And over the last 5 years, it's gotten a lot worse, and it never went away, and nothing seemed to help. And then I was diagnosed with stage 3 colon cancer, and I had basically a lacrosse ball sized tumor that was bothering my spinal cord and everything sort of down in that neck of the woods. So now, granted, like you said, that is an extreme case, right? That's not every day, but I think as coaches, especially me, I'm always telling, my staff and people that I work with, hey, look, like, if you get to the point where you can't figure it out, maybe this is just something that you can't figure out, and you need to go ahead and you need to do your due diligence and go through the process of finding the right clinicians and medical professionals. And when it is time for imaging, it's super important, because that's just one of those things that could be potentially adding to it. Yes, did I have disc issues in the past, and did I do some dumb things when I was lifting as a young athlete? Absolutely. But at the end of the day, I got that surgery and got my tumor taken out, and my back felt better. A bunch of other things felt like crap, but my back felt better. So it's a pretty extreme example, but it's important for people to understand, especially when they're dealing with low back pain. There's so many things that it could be, and it's multifactorial. And why would you guess? Like, why would you just be like, it's probably nothing if you can't figure it out? To me, that is just, that's the worst thing you can do.
Right. Yeah, no, 100%. That's absolutely, it's almost like borderline negligence. You found a problem, you found an issue, just because you don't know what to do with it, just because you don't know how to handle it, you just dismiss it, right? That's definitely an inexcusable approach. And, therapists and strength coaches, for the most part, I feel like have a pretty good perspective of individual limitations. Like, I think I'm a fairly good clinician that has decent manual skills and decent diagnostic skills. I know the limitations. So when I reach the point where I've kind of done everything I know to do or can do for a patient, and if that's not helped them, I either need to get them off to someone better than me, or I need to get, more advanced medical procedures. What I shouldn't do is just keep banging my head against that rock using direct access for, years and years and years, and letting a potentially festering problem get worse. Right. So I think have the bravery, have the courage as a healthcare provider, as a fitness professional, to know when you're kind of out of your lane, or know when you've just got the limit of your capability, and make the referral to the next level of care. It's totally fine. It's what we're supposed to do.
Now, when we have this discussion, I always preface it saying, if this scares the shit out of you a little bit, good, because this is real stuff that could walk in your office. If Mike walked in your office and you hand them a lacrosse ball and say, here, roll that out, that's negligence. Now, on the other side, it's also hopefully getting everybody to up their game because of the impact that we can have. And I tell a story of a fork in the road that we can have. And if you look at, and you kind of alluded to this before, and the story that I use is actually a guy that we both know, Mike Contreras, who does a lot of work with working with utility workers out in California. And I was out doing some work with him, and I remember having a guy come up to us. And he goes, hey, Mike, you remember me? And he's like, I'm sorry. He says, well, you probably don't recognize me. I lost 100 pounds. And he says, wow. He says, really? He goes, that's awesome. What happened? He said, well, I've always had pain. And it's not that I didn't want to work out, it's just that it sucked. It always hurt. And then, what he did is he went into these electrical workers, and he gave them things to improve their movement after doing some movement screening on them. And then that was part of what their job was. As part of their safety meetings, they had to go do a series of drills based on what their category was in terms of their movement deficiencies. He said, I started doing those and I started feeling a little bit better, started going for walks. And then I started going for walks, and then I started getting to hiking, and then, start exercising more. And I didn't want to go home and eat crap. So I started eating better. Lo and behold, I'm off medications. And next thing you know, here I am a year later, and I feel great, and I'm 100 pounds down. Now, he hit a fork in the road, and Mike happened to be the guy to bump him in the right direction. Now, let's say if he doesn't get that, let's say if he goes and he gets the cookbook, whack 'em and crack 'em, heat ultrasound stim, 3 times a week, and he goes. Well, there's 3 things. He's got 3 options. One, the doctor is first going to send him to PT. He goes to that PT and he gets that kind of off the rack treatment. What's going to happen? He's going to come back in a couple of weeks and he's say, well, PT didn't work. He's a failed patient. So now he's down to 2 options. He's got drugs or he's got surgery, and or both. And like you said, that's a really slippery slope right there when you talk about the level of addiction to opiates and the high level of failure in surgery. And then what's going to happen? Not only does the back pain or whatever pain not go away, but now this guy, he's been labeled as failed. He always hurts. Do you think he wants to get up and have a kale salad, or go for a walk anytime soon? Like, that is so impactful on someone's life if you can do it right.
Mm-hmm. Yeah, could agree more. I mean, it's truly setting them up for failure, because they get in their mind that then they're broken, they can't be fixed, and I failed PT, I failed surgery, and it's again, the pain, neuroscience of pain is a real thing, that we learn more and more about that. But, certainly people that go chronic with these back conditions, and there's some fundamental chemical changes in the brain, and it makes them more prone to having more symptoms and being more fearful of movement, more fearful of things like physical therapy and exercise. And, I've always said a lot of the people that are overweight, that are trying to improve their lifestyle, they're trying to exercise more, they're trying to help themselves, a lot of times they encounter orthopedic issues first, right? They encounter knee pain, back pain, whatever, and it creates a bad situation and a bad day for them. So they just say, well, I'm just not going to do that anymore. And then it's a vicious cycle, because then you get cardiovascular risk factors, musculoskeletal risk factors, metabolic risk factors, you name it. And that's obviously an issue. So we got to do it right. And a lot of times we only have 1 or 2 shakes at it. But if we don't set the patient up on the right pathway, we may have done some damage that's really hard to recover from.
Now, let's go one more thing just to drive it back the other way. So we talked about how the musculoskeletal may show up, and it could ultimately drive to deleterious lifestyle implications. Well, what about when the lifestyle drives the musculoskeletal? You talked your story about breathing and how that changed, and how much of that was not anything musculoskeletal, joint, muscle, anything lengthening, strengthening, or changing of anything other than you created a shift in their autonomic nervous system by getting them to become a little more parasympathetic and out of that fight or flight type of situation. So, Mike alluded to before about lifestyles factors that may play in that, your mobilization, your stretch, your exercise isn't going to overcome, like you said, the guy who's drinking Mountain Dew and smoking a pack a day and not sleeping.
Right. Yeah, no, it is. I mean, it's in a relatively healthy young, a sample of PT students. You have all those people that can't touch their toes and get better with breathing, and it's probably not musculoskeletal driven per se. It is probably very anxiety driven or stress driven, right? Because they're PT students, they're studying all the time, they're sitting in chairs all day long, they're they get out of that high threshold strategy a little bit, all of a sudden things open up and move better. But 100%, I mean, it's not everything has to be a muscle or a joint problem, right? And I feel like when you're a physical therapist, and again, I'm a physical therapist, so I can say this about the profession. Sometimes it's a license to stretch and strengthen. And sometimes the first thing you need to do is question, well, why is it tight even to begin with? And is exercise the first solution? And in Mike's case, exercise is not the first solution. It needs to be something completely different, right? And then to a little bit lower level, to a lesser degree than stage 3 cancer, there's a lot of folks out there that, yeah, I can stretch your neck and I can stretch your back and I can make you feel better for 30 minutes that you're here, but you go right back to your desk job where you're sitting hunched over in bad ergonomic position and you're doing that for 8 hours a day, 5 days a week. I'm going to lose. Doesn't matter how good of a therapist I am. I'm losing that battle, right? So I think the environmental factors play a large role. This is where we have to get better at educating and telling patients exactly what has to occur for the healing to be optimized. And starts with good diagnostics, good coaching, good pathway, good plan. You got to get buy-in. You got to get them to stick with you because, like you guys have both alluded to, right now, what happens a lot of times, I have pain. Someone talks me into going to therapy. I do it. I have a bad experience. I waste a lot of time, waste a lot of money. I end up down the medical pathway that ends in surgery, and I'm not even a lot better because of it. And you think the next time that they have a problem, they're going to go to therapy again? Or their friend or their kids that have problems, you think they're going to recommend therapy or recommend that path for them? Not a chance. And those are become the statistics of people that are living with musculoskeletal pain every day that aren't seeking care, right? We got to change that.
Scary stuff, but it's very, very informative and incredibly impactful. So before we wrap things up, Mr. Perry, any last things that you want to throw at it?
I mean, when it comes to low back pain, I think we could probably be here all day, but I think sort of one last question I just want to throw in is, and this is really just for the younger athletes. I feel like these kids just aren't recovering, right? They're just doing too much day in and day out. And let me ask you this: how much of a lot of these issues do you feel are simply overscheduling and not just having enough time for a little R&R?
I think a lot of it, and that's quickly becoming one of the biggest factors, like environmentally too, especially for the younger kids, is their schedules are crazy, right? You're up at 6, you're at school all day, you got practice after school, and then maybe even like another type of event or club meeting after that. You're at home, you're doing homework, then you want a little time for video games, you want a little time for friends. You're not getting to bed till midnight, and then you're up again the next day, and then on the weekends you're traveling to games. Some people are playing multiple sports and during the same season, right? And there's no off season for these kids either because they're in travel ball, they're in other leagues, and so again, it just never stops. So I do think that's a very valid point, that under not getting enough sleep, not getting enough rest, and then when you are on the road, when you are engaged with all these clubs and different sports, it's real easy to say, well, I'm not going to get home and get a good home cooked meal either, so I'm going to pick up the sandwich from the gas station or grab some Mickey D's, and now you're compounding under recover, under sleep, stress with bad fuel in the system, and now you're expecting this Corvette to run at high performance. And it's eventually the rubber's going to meet the road, and you're just going to run out of chances, and something's going to break down.
The take-home message, kids: gas station sandwiches are the end, they are gateway drug to the end of everything that you ever wanted. And then, you add all that on top of really bad physical literacy as a baseline, because we don't have PE, and then it's a recipe for disaster. But this has been awesome as I expected, Dr. Matsel, and you are a man of many hats who has, about as many jobs as someone can have. Tell me what you got next on the agenda in your life.
Well, thanks. The most immediate, I guess, thing that we're doing is we just launched a PhD program here at the University of Evansville. It's a first PhD program kind of here at in the Evansville area. We've got several clinical doctorates, but this is truly a academic research focused PhD. So we've been working on this for a couple of years. Really, the mission at UE has always been to be part of the solution. And what we've found is that in healthcare, there's so many healthcare shortages out there with nurses, therapists, physician assistants. There's a lot of burnout in healthcare. It doesn't really matter what field you're in, you name it, people are wanting to get out of it. And also from a faculty standpoint, there's a lot of people nearing retirement age that are going to not be teaching anymore. and you compound that with all these new programs that are developing. I mean, blink your eye and there's a new online PT program going up, and it's the same thing with physician assistant, pharmacy, you name it. They're all growing at a rapid rate. You got to have faculty to be able to even teach these folks and to teach them well, right? We don't want to just machine operate, professionals out there. So really, we created this program under the intention of trying to train the next generation of educators, so that will trickle down to the next generation of healthcare provider. So it's an online program centered out of the University of Evansville, 2.5-year doctoral program that you can get your PhD on. They talked me into being the program director. So if you have questions, you can reach out to me for that. But that starts in January. So our first cohort.
Exciting stuff, spectacular, and we definitely need to get that out there. We don't need any more machine manufactured physicians out there. As they say, Mr. Perry, somewhere out there is the world's worst doctor, and Monday morning someone's got an appointment with them.
Yeah.
All right. And with that, we'll wrap it up. We want to thank you, Dr. Matsel, and thank you, Mr. Perry. And this has been the Principles of Performance podcast. Thank you for listening to the Principles of Performance podcast. If you've enjoyed our content, please like and share on your social media outlets, as well as subscribe and give us a review on YouTube, Apple Podcasts, or whatever your preferred platform is to listen to. For more information on the Principles of Program Design courses and workshops, visit us at www.principlesofprogramdesign.com and follow us on all of the social media channels where we post new content every day. To save 10% on any PPD courses, enter the discount code PRINCIPLESPODCAST10 at checkout. If you have any questions we can answer or suggestions for the show, you can email us at info@principlesofprogramdesign.com or message us on social media. Thank you again for your support.